Joe, and sorry for these inconveniences and this unlucky start. Anyway, we are on now, and let me see. Yeah, we are not only unlucky with the start. Now, hope you can see this now. Yeah, so what I will do is to give you now a first little brief of an outline of the talk. So I'll present some results showing that social inequality was a forgotten factor in pandemic preparedness before the COVID-19 pandemic outbreak. And I also like to speculate a little bit why I believe this was the case. Secondly, I'll present some results on social inequalities in COVID-19 pandemic disease burden. And I'm going to focus on studies that were published in 2020 to sort of avoid the sort of confusion of getting in vaccines, and also vaccines being a social disparities potentially in the vaccine uptake playing a role initially. So I'll focus on the first waves of the COVID-19 pandemic. And I will also call for more research, especially on the mechanisms for these disparities that I'm going to show you in a second. And finally, I'd like to discuss how we can take both medical and social vulnerability into account in pandemic preparedness to be better prepared, not only now and also for seasonal flu pandemics, but also for the next pandemic, which could be caused by flu or coronavirus or a pathogen X for that matter. And so for 5 years ago, I was doing one paper which I published in the Journal of the Norwegian Medical Association. And here I did two things. I was searching the literature on the 1980 flu pandemic and the 2009 so-called swine flu pandemic, and was looking at those studies that looked into the issue of social inequalities. And secondly, I was studying influenza pandemic preparedness plans to see whether they took social disparities or social inequalities into account. And I was particularly looking for whether risk groups were not only medically defined, but also socially defined and an indication for vaccination. And that could, for example, be whether a poverty area were prioritized for vaccines, or whether, for example, people living in a household with low income, for example, would be prioritized for vaccination. And I was also looking for whether the models in these that were used in these pandemic preparedness plans and the effects of non-pharmaceutical interventions, including vaccination, and also non-pharmaceutical interventions, and how they had an impact on different disease outcomes, and whether these were broken down by socioeconomic status, could be income, could be education, and so on. So given the fact that in this paper found quite a large bunch of literature showing indeed large social inequalities, especially in pandemic mortality, both in 1918 and 2009, and also the fact that that inequalities have been widening over time, especially when you look at income and wealth indicators, as shown by the economist Piketty, and also given the UN SDG goals, such as eradicating poverty within 2030, ensuring good health for all, and reducing social inequalities of health. I was just totally baffled by the fact that none of these plans that I looked into actually discussed social inequalities at all and how to reduce social inequalities when a next pandemic was coming. And this was the case both for Norway, for Sweden, for Iceland, for Switzerland, for Turkey, for Macedonia, the United States, for Canada, Australia, and even the WHO pandemic preparedness plan didn't mention social inequalities and how to reduce social inequalities when the next pandemic was going to come. And we were thinking at that time in 2017 that the next one would be caused by flu and not coronavirus. And so I was just totally surprised by this. And all of the 28 member states in the EU did not even discuss this at all either. So then I was left with the question, why was these issues totally forgotten? And I thought maybe it could be that those that actually have these plans, and they would basically be countries in high-income countries in the Western so-called industrialized world that had written these plans. And in these countries, the main causes of deaths are these so-called NCDs, could be heart disease, lung disease, chronic diseases, and so on, right? So maybe we have had a focus in these countries on these NCDs and how to reduce social inequalities in NCDs, maybe at the expense of infectious diseases, for example, influenza. So I've seen a couple of reports in Norway looking at how to reduce social inequalities in health, but they don't mention, and this was in 2017, and then didn't mention how to, for example, reduce social inequalities in, for example, seasonal influenza. So we actually don't really know much about the social inequalities in who's dying from seasonal influenza. And secondly, maybe those that have written these plans have thought that everything is social neutral beyond chronic disease status. And by that, I mean that one might have thought that, one should just control for underlying comorbidities, which could have a social profile. You would eventually just also, capture the social inequalities in the chronic disease status. So you don't really have to control for social inequalities or socioeconomic status indicators such as income and education and so on. And maybe there's have been a lack of focus also on how ethnic inequalities and socioeconomic status may have had an impact, on exposure risks and also health literacy status and access to healthcare, which also matters when you are studying the disease outcomes from pandemics, including influenza or COVID for that sake. Maybe who writes these plans matters too, because when you think about it, maybe it's basically people coming from the hard sciences, from math, from medicine, from biology, from immunology, virology, and so on. So maybe they also overlook, the lessons coming from humanities and social science. And finally, maybe also medicine has its master status in science on influenza and on diseases that can turn into pandemics, and also a sort of a master status in the policy field and the practice field as well. And it's not only people that work in this field that might have thought that these diseases are social neutral. We see here a picture of Madonna too, thinking and saying that this is the great equalizer, and she was talking about COVID, of course, and what's so terrible about this, it's what's great about it, because we are all in the same boat, so to speak. That was her impression, by the way, in March 2020. I was not the first to sort of come up with this idea that social inequalities is a forgotten factor in pandemic preparedness. So already prior to the 2009 flu pandemic, there was a large body of literature coming to the same conclusion, and a couple of the references are shown here. But the interesting thing to me, though, as a researcher on pandemics and flu pandemics in particular, is that after the 2009 flu pandemic, a lot of new studies also came out showing large social inequalities in pandemic outcomes during that pandemic in terms of infection rates, hospitalization rates, and mortality. So it's so curious to me that these plans after 2009 were not updated to take those inequalities into account, to be better prepared for the next pandemic that came, as you know, 10 years later with the COVID-19 pandemic. So I'm not surprised at all to see that, so given these increasing inequalities both within and between countries over time, as Piketty documented, and also the fact that there's little focus on social vulnerabilities and social inequalities in pandemic preparedness plans, I'm not surprised at all to see it's the same groups that are having or paying a higher toll also during COVID. So it's the poor, it's the immigrants, Black people, and some indigenous people are once again hard hit, like we've seen with prior pandemics, like the 1980 Spanish flu pandemic and the swine flu pandemic in 2009. So I think that this study at the top here for the UK is particularly interesting because it actually shows my point. And that's that if you control for medical risk groups or these NCDs underlying comorbidities, the impact or role of being poor or having a migrant background is still important. So being poor, being a migrant, and having underlying comorbidities actually played a role in explaining the mortality in the UK during the first waves of COVID. And I go now down to the studies that have been done for Sweden. I think they're quite interesting. For example, migrants there also have a higher mortality, and also those with shorter education. But what is so curious to me is that migrants in Sweden, they had lower mortality, and especially for the NCDs before 2020 and even under COVID-19 pandemic, but they had higher mortality from the coronavirus that created the COVID-19 pandemic. So this is so peculiar to me. Why is this so-called healthy migrant effect not protecting the migrants from a infectious disease, while that seems to, if that's that sort of hypothesis of the healthy migrant effect is valid, why is it only protecting the migrants, when it comes to NCDs, but not a infectious disease such as the coronavirus? And the Refal et al. They concluded also that living in multi-generational households were a risk factor controlling for a number of factors, socioeconomic status, and migrant status, and so on. But they also showed that language barriers were not among the main explanations in Sweden, because immigrants who live with Swedish-speaking persons had the same or slightly higher risk of dying as those who live with other foreign-born in their household. But we are we cannot still conclude on why migrants have a higher mortality toll. And so what I think I've seen from reading the COVID-19 literature, but also literature on influenza and influenza pandemics, is that we actually know too little about the various mechanisms for why we see these differences and disparities in severe outcomes during during pandemics. So here's just a framework I've stolen and adapted from and revised a little bit from Quinn et al., showing that social inequalities, geography, race, ethnicity, and so on, migrant status, can have an impact on exposure risks and susceptibility and access to care, and all of these things can translate into disparities in disease outcomes. But what I'm claiming is that the focus in and the science on flu and on pandemic diseases is that it has focused on mechanisms too here. So basically, we have been looking at the underlying comorbidities at the expense of exposure risks and also access to care and health literacy and so on. And so even in Denmark, I believe that the migrants have paid a higher toll, and that has been the case also in Norway. And so there's still a bunch of ideas of why the migrants in Norway have paid a higher toll. There's been a study controlling for a number of socioeconomic status measures and crowding and so on, but couldn't sort of explain away the migrant effect. So there's ideas about higher exposure in the households, so more crowding at work, maybe via so you have if the migrants are for example having work in healthcare settings or as a taxi driver and so on, they might have initially in 2020 been more exposed to the virus and so on, and lived in multi-generational households. Maybe there's genetic factors going on, maybe there's even vitamin D deficiencies have been tossed out as an idea to explain the migrant toll in Scandinavia. Maybe several of the migrants also went home and were exposed at home in their countries of origin and came back with the virus and so on. There's just tons of ideas about why they have been more have paid a higher disease toll. But we still cannot conclude on this, so we just definitely need more studies to look into the reasons why the migrants and other socially vulnerable groups in Scandinavia and elsewhere have been so badly hit. And of course, in the setting in 2020, without the vaccine being rolled out yet, the uptake of non-pharmaceutical interventions are of course important. Here's just some results from a study that we did here in Norway, and where we looked at the role of income and education on different non-pharmaceutical interventions. This study unfortunately didn't capture the migrants. We are doing now another survey where we have captured more migrants, but this study from 2021 shows that that most people washed their hands more than usual, kept 1 meter distance. Few used face mask in the first wave of the COVID-19 pandemic in Norway because it wasn't recommended at that time. But you basically see a little bit of a social gradient, especially when it comes to working from home. So that might have played a role in explaining the social inequalities in the pandemic outcomes and also the ethnic inequalities in the pandemic outcomes, both in Scandinavia and elsewhere. And I could have showed you the results for education here too. So you see a little bit of education and income gradient also in terms of using less public transportation in a private and a work context too. And finally now, after the vaccine came available last year, vaccine uptake might matter too when you want to explain the social disparities and the ethnic disparities in pandemic outcomes, of course. So, but curiously enough, still we've basically seen a lot of studies looking into the role of socioeconomic status in the intention to take the vaccine. So we actually need more studies that look into the role of SES and ethnicity and the actual vaccine uptake and also attitudes. So we definitely need more studies here on this topic. So now I want to turn to the question what we can do better to be prepared for the next one. So first of all, we need to realize that we may have combination of waves, even of seasonal flu that can come back. You know, we haven't had much of flu here in this country. I don't think you have seen it in Denmark too this season. And seasonal flu, as you know, basically disappeared when we had all of these strong measures in place and lockdowns and so on. But now, when we have opened up, we might have, waves of both flu, RSV, and COVID-19 going on at the same time. And even the seasonality of flu could actually change by us having gone through COVID and also have had these quite successful measures to sort of stop the diffusion of COVID. So it could actually, we could actually end up having flu, for example, in even in May and June, when we normally have it, in January to March. So that could actually happen. We will have new pandemics. They will come, and they could even be worse than the one we have now. And I think it's important that we reduce social inequalities in wealth and in income and in housing and education and so on, and also that we reduce the social inequalities in the NCDs. And we need to think syndemically, like Horton said in Lancet in 2020, because what he said was that we are in a syndemic, not a pandemic. And it means that we simply don't have just one infectious disease. I mean, that would be COVID, but we have multiple diseases, so we have an array of all of these non-communicable diseases as well, interacting, on the backdrop of social inequalities. So we need also to reduce social inequalities in the NCDs and in all other areas where that can have an impact on disease outcomes as well, and it includes income inequality, education, housing, and so on. I think we need to recruit broader in science and practice too. And I looked at the pandemic and epidemic committee here in Norway. Before COVID, it consisted of 20 people. And of course, we're talking Norway here, so it was a perfect gender balance. It consisted of 11 women and 11 men. But all of these people have a background in hard sciences and medicine, and none of the people there in that committee have a background in social science and humanities. And it's basically the same people that have been, giving the government's guides on how to react to COVID-19 here in Norway. So they have basically a background in medical science and not in humanities and social sciences. And I think that that's a weakness. We saw it also in the UK, a similar study. This was a I think going on in Guardian, and they looked at the committee there in the UK, and only 2 people in that committee in the UK had a background other than medical science and statistics and math and virology, immunology, and so on. And I think when you look at the global scale, there was this study in the global BMG Global Health in 2020 showing that only 4% of 115 COVID response groups in 87 countries had the gender balance, and 85% were male dominated. So I think there's nothing wrong with men and nothing wrong with medical doctors and so on. But I think there's a danger of us creating an echo chamber when one gender and different science people are left out of the discussions and the debates, and those that are making the policies both before a pandemic but also during a pandemic. Finally, there was this paper also in Scientometrics in 2020 showing that only 4% of the papers that came out on COVID from January to May 2020 were from the social science and humanities. We actually need more studies on this topic, on COVID-19, and on other pandemics coming from the sides of the social science and humanities. I would also say that a pandemic is not only about hindering infections when we do lockdowns. It's also about mental illness, related to lockdown, related to unemployment during lockdown. It's loneliness and so on. So it's just a bunch of other issues that are at stake too when you are doing heavy measures and lockdowns and so on. So I say, look to Germany. So when they opened up in 2020, they were inviting philosophers, historians, school researchers, and social scientists, also to discuss how to open up Germany. So I think that's a learning point. Look to Germany, look to other countries where they have invited in different people with different backgrounds. I think then and only then you can also, do a very good job here in tailoring the measures and also tailor how to open up societies when we have locked societies down. And what else? Yeah, I also say that medical risk groups, they are not socially homogeneous. They are totally heterogeneous. So it's not like if you just control for underlying comorbidities, then everything is socially neutral and beautiful. Risk groups, medical risk groups, they are totally heterogeneous. So we have shown in a new paper also that people, with short education and less income, and also people on disability pensions, they have a much higher risk of being in those medical risk groups. And I just totally can't understand that a person with a heart disease, for example, growing up on the west rich part of Oslo, have the same risk of going through a severe disease compared to a man with a heart disease growing up on the eastern parishes of Oslo, which have much worse living conditions. So we definitely need to think about these risk groups as not homogeneous. We need to take social inequalities in pharmaceutical interventions into account in both public health work and in plants. And we need to define risk groups not only by medical indications, but also by geography and social determinants of health. And I think here's a couple of examples of suggesting this. And this one is from the WHO and from SAGE. And this was just before the COVID-19 vaccination programs were rolled out. And as you can see from the slide, there's a lot of going on this slide, but you see here when vaccines are scarce, at least in stage 2 here, WHO is suggesting that social demographic risk groups should also be prioritized for scarce vaccines. So it is actually possible to suggest other risk groups than the medical ones during a pandemic, which you see here. Here's just another example. This is coming from the US, from the National Academy of Sciences. And basically, you once again see that those that are supposed to be prioritized are the high-risk workers, healthcare workers, people of high age, and people with comorbidities. But you also see this little bit of a circle around these 4 phases. It says here at the bottom that in each population group, vaccine access should be prioritized for geographic areas identified through the CDC's social vulnerability index. So it just at least suggests that you can think about both social vulnerabilities as well as medical vulnerabilities when thinking about distributing scarce vaccines. So I'm going to end here by talking just briefly about how we did it in Norway. So once the vaccines became available, we started to roll out the vaccines. This was January 2021. And what we did was that the GPs, they did a list of the sickest of their patients, right? Those with underlying comorbidities. They were supposed to be prioritized and get the vaccines at the GP office. At the same time, we also distributed vaccines according to one key. And that key was the share of people above the age of 65 in each municipalities. So if you had a higher share of older people, you were going to get more vaccines than other municipalities having a lower share of people above the age of 65. Okay, so this happened in January 2021, and then there was a big debate about whether we should also roll out vaccines to areas harder hit. And areas harder hit were basically Oslo and some southern cities, southeastern cities in Norway during the whole of 2020. So there was a big debate about whether geography should be used as an indication as well. So areas of Norway having a high disease burden should also get more vaccines, in addition to areas having a higher share of people above the age of 65. But this was a debate that went on for 3 months. So in March, finally, the government started to say that, oh, we are going to do a skewed distribution now at the city level in Oslo. So 6 parishes of Oslo eventually got more vaccines because they had a higher disease burden throughout 2020. Okay, and there was a couple of other cities down south in southeast Norway too that got more vaccines and earlier than others, and not just given the share of the people being above the age of 65. So indirectly, of course, this policy of shipping more vaccines to the eastern parishes of Oslo, then you indirectly also capture the migrants and the socially vulnerable, because the most socially vulnerable people in Oslo, in Norway and in Oslo, they live on the eastern parishes of Oslo. So indirectly, you sort of sent more vaccines to migrant communities and socially vulnerable communities, right? But in my opinion, I think we should have distributed the vaccines already in January based on 2 keys. That key of the share of people being above the age 65, which would capture the old and those with comorbidities, but at the same time also an index based on living conditions. Because if you had done that, you would immediately and directly admitted that you would have known that those that were most vulnerable, both medically but also socially, would be captured and get vaccines early on. And our prime ministers, said in all the debates, the debates in 2020 and 2021, that the paradigm shift in pandemic preparedness and policies were to do the lockdowns. I would say it's actually using geography, which is the big paradigm shift, and not only the medical risk factors, as indications for distributing vaccines, and especially scarce vaccines. So I'm going to conclude here by saying that next time we need to take both medical and social vulnerabilities into account. And I mean, we have seen the big social inequalities in health and wealth for at least 100 years in Oslo. So we should have known beforehand that the eastern parishes of Oslo would have been hardest hit, both by having higher infection burden, but also more hospitalizations and more deaths, just because of the fact that they are so much more socially vulnerable, those that live on the eastern side of Oslo. So we should have said it just immediately that both socially vulnerable and medically vulnerable should be prioritized for vaccines. So I think I'll just stop there and thank you all for your attention. I thank our team and collaborators and funders, and I apologize so much for the starting problems and all of it, and are keen to have any questions and comments.